Good afternoon, everyone. Thank you for joining us today in the webinar on the way to the integration of the migrant population healthcare policies. We will begin in a few minutes. Some of our presentations will be held in Spanish, so we recommend that you follow the steps that you see on the screen to activate the translation. In case you need assistance, feel free to write in the chat box. Remember that if you are on your cell phone, you will not be able to activate the translation. This session will be recorded by saying you are agreeing to the record.
Good afternoon, everyone. My name is Paula Pinzon. I'm the Communications Specialist of the Comunidades Saludables program of USAID. In the name of the program and the Ministry of Health and Social Protection of Colombia, we welcome you to this webinar called On the Way to the Integration of Migrant Population Healthcare Policies. In the last 5 years, we have witnessed how Colombia has become a host country for the migrant population. In this context, the inclusion of the migrant population in our society, especially the health system, has presented a great challenge that we seek to face through joint work, the identification of good experiences, and the creation of strategic alliances. With the aim of sharing lessons learned from integration policies for the migrant population and identifying inputs for the formulation of health policies in Colombia, this webinar is part of a joint effort between the Ministry of Health and Social Protection of Colombia and the Comunidades Saludables program from USAID. Without further ado, we begin this event with a few opening words by Dr. Germán Escobar, Chief of Staff of the Ministry of Health and Social Protection. Dr. Germán Escobar. Thank you very much, Paula. Thank you very much to all the attendees, to my fellow panelists, to the people who are going to participate. A very special greeting to Dr. Nora, our USAID health specialist, and to Dr. Miguel Pulido, the person in charge of Comunidades Saludables. As we saw in the introduction, this forum is of vital importance for the formulation of informed policy around the migration issue, with better inputs and, above all, with greater capacity for legitimacy in the face of the population, gathering the experiences not only of Colombia, but also of countries that have faced a phenomena of this nature. In this sense, I also want to extend a greeting from Minister Fernando Ruiz, who, as we all know, is currently attending our disaster situation in our island territory due to Hurricane Iota. Conversing with him prior to this forum, we wanted to give the message of how important it is to have these spaces for discussion, these spaces for exchange and reflection, in order to build a better public policy, to consolidate the actions that we have been taking as a state, such as government, and as a ministry. It is important to highlight the work that we have already been developing with USAID and within the framework of the Comunidades Saludables project, where we have been able to train personnel from the territorial entities, where we have been able to take interventions to the territories directly affected by the migratory phenomenon. And the great challenge here is for the public policy to ensure that recipient populations and migrant populations have conditions of access to health services throughout the continuum of care, conditions of opportunity and effectiveness. The Colombian health system is one of the priority elements for the social development of our country, and in that same sense, we could not continue a development agenda if we do not strengthen the health system and find ways for the migrant population to have full access to health services under the conditions that are provided within our regulatory framework. Finally, it is important to aim for a comprehensive health policy with a long-term perspective that aims to achieving dialogue with other sectors and achieving an intersectoral vision to be able to face this phenomenon that affects Colombia and many other countries because of the cases that we know well. So I want to extend a very special greeting from this ministry. I want to thank you for your invitation, USAID, the Comunidades Saludables program, and all the panelists who are going to accompany us today, so that in this framework of reflection we can obtain conclusions that will continue to nurture this regulatory exercise of the Ministry of Health. And we hope this will be a very prolific afternoon of ideas and conclusions on this matter. Thanks a lot. Thank you very much, Dr. Escobar. Let's now listen to Dr. Nora Maresh, Deputy Director of USAID's Venezuelan Response and Integration Office in Colombia. Nora Maresh. Thank you very much. Good afternoon, everyone. It is very pleasant to be here with you today in this first virtual meeting of our Comunidades Saludables program. As Deputy Director of USAID's Office of Venezuelan Response and Integration, this is a very significant moment because it represents an important advance in our work to support the response of the government of Colombia to the migration phenomenon. For more or less 2 years, we have been focusing on this issue, and today we have the office where I work, an office for the response and integration of the migrant population through economic integration, the protection of human rights, education, and the health of Venezuelan migrants, Colombian returnees, and host communities. As part of this effort is the work we are carrying out in the health sector through our Comunidades Saludables program. With this initiative, we seek to influence the attention of the Venezuelan migratory phenomenon and strengthen the Colombian health system with tools that contribute to its resilience and response capacity in a comprehensive, inclusive, and sustainable way. There is an international consensus that recognizes migration as a social determinant that includes changes in lifestyles, socioeconomic, social, and community conditions. Understanding these phenomena is essential to find alternatives and create strategies to favor the quality of life of the people who have been most impacted by the massive flow of migrants from Venezuela. That is why these spaces for socialization of knowledge and experience are so important, and for USAID, it is very valuable to be able to support them. We also know that by accessing quality health services, migrants will be better able to continue to the development and reactivation of the economic sectors that have been most affected by the pandemic. And that will undoubtedly facilitate the integration of this population into the territory. Today, we also want to highlight the decision of the Colombian government to promote a comprehensive, inclusive, and sustainable health policy that seeks to promote greater affiliation to the general system of social security and health and facilitate access to quality health services for the migrant population and communities receiving. In conjunction with the Ministry of Health and Social Protection, we have created this space to share lessons learned at the local, regional, and international levels, which serve to inform the creation of a national health and migration policy. This is, in essence, the goal of this webinar. The Colombian government faces a challenge where it must be able to offer social services to migrants fleeing Venezuela due to social, political, and economic instability. For this reason, their contributions will be very valuable for the formation of these local capacities and the strengthening of a health system capable of meeting the demands of the entire population, including migrants. Thank you for your participation. Thank you very much for your intervention, Dr. Maresh. We continue with the greetings from Dr. Miguel Pulido, Chief of the Party of Comunidades Saludables program. Miguel Pulido. Respected Mrs. Vice Minister of Social Protection, Dr. Maria Andrea Godoy, respected Mrs. Nora Maresh, Deputy Director of the Office of Venezuelan Response and Integration of USAID, respected Dr. Germán Escobar, Chief of Staff of the Ministry of Health and Social Protection, respected Dr. Lucas Gomez, Manager of Border, respected Dr. Midori Dehavich, Global Technical Director of LHSS, respected panelists and participants, receive a kind greeting on behalf of USAID's Comunidades Saludables program. As Director of the Comunidades Saludables program of USAID, it is an honor to be here with you and witness this webinar, the product of teamwork with the Ministry of Health and Social Protection. This seminar has the purpose of sharing knowledge, experiences, and lessons learned that allow the country to advance towards a systematic, comprehensive, and sustainable inclusion for the Venezuelan migrant population and host communities. Our Comunidades Saludables program is part of the USAID Local Health System Sustainability Project, which aims at contributing to the strengthening of health systems in 52 countries around the world. The Comunidades Saludables program in Colombia has the great challenge of contributing to the integration of the migrant population in a sustainable way, and I share with you that we took it very seriously from day one, and that regardless of the obstacles of the COVID-19 pandemic, USAID Colombia managed to start activities of this program. Today, we will see one of the many results that have already occurred in these months of work. This is the first space for collective construction that we are carrying out together with the team from the Ministry of Health and Social Protection, and we are sure that it will be the beginning of many more. The lessons, experiences, and knowledge that we will show today will contribute to the construction of a national policy for the integration of the migrant population. Thank you very much for being a part of this space, and welcome. Thank you very much, Dr. Pulido. Finally, Dr. Lucas Gomez from the Border Management shared with us a video of the greeting for this webinar. Hello, I am greeting you from the city of Cucuta, where, due to environmental emergency issues, I had to travel. I want to send you a very special greeting. I would have loved to be talking with you today about one of the issues that is perhaps most important for border management, which is the issue of integration. The integration also that occurs from the vocation that we have in Colombia and those policies that we have generated of integration in health issues. I believe that there Colombia is sending a message to the world, a message of openness to provide comprehensive care for the migrant population, but that does not come without risks and without big mistakes. Here in Colombia, we have to make a big bet for the integration of migrants in the medium and long term. It is not simply the issue of emergency care as it is taking place at this time, but the reflections that are going to be given here today are complemented with that great policy that we want to have in the medium and long term, where we go from talking about migration to talking about integration. In Colombia, we are betting that 1.5 million to 2 million Venezuelans who are in our territory and those who are going to arrive can be fully integrated into the systems, starting with the health system, and that is a great bet that we are working on with the Ministry of Health, with Colombian Migration, with the Foreign Ministry, to enter into regulation schemes that allow the pressure on public hospitals to be lowered a bit. Many thanks to Dr. Gomez from Border Management, and thank you all for your opening remarks. We now begin the first thematic segment, from the humanitarian response to a systemic and inclusive policy, a health challenge in Colombia, in which the accumulated experience in the challenge of transitioning from emergency and humanitarian care to a gradual, comprehensive, systemic, and sustainable inclusion through health care for the migrant population. This segment will be moderated by Dr. Midori Dejavic, Global Technical Director of the Local Health System Sustainability Project, and will include the participation of Dr. James Fitzgerald, Director of Health Systems and Services of the Pan American Health Organization, Dr. Alexander Adnikov, Regional Specialist in Migration and Health for the Americas, and Dr. Julian Fernandez, Director of Epidemiology and Demography of the Ministry of Health and Social Protection of Colombia. Dr. Dejavic, the floor is yours. Thank you very much and good afternoon. And also a very good morning and good evening to those who join from other parts of the world. The United Nations reports 277 million international migrants in the world for 2019. This is therefore a complex phenomenon that involves the lives of many people, their families, and their communities. From a review of the literature we have done, we know that there is a set of international norms and in many cases national ones that are fundamentally inscribed within the human rights framework and certainly raise the importance of the rights to health. They also recognize the health sector as a fundamental pillar, as mentioned a moment ago. From the literature, it seems that we have a good case in favor of extending the protection of the health system to all migrants. The evidence would show that providing health care to migrants effectively has direct and indirect net benefits for the recipient countries, clear benefits for the public health, and of course, a factor that contributes to social cohesion. In addition, and this is something that we will surely discuss during the seminar, strengthening primary health care in particular generates great benefits and savings in the medium and long term. So, if the literature is showing us some of these ideas, the question we ask ourselves is, what do the countries, Colombia in particular, require to implement the international agreements signed and address this complex phenomenon? Certainly, the importance of generating health policy that is sensitive to migrants has already been formulated. We are pleased with the great efforts that Colombia is making in this regard, and we have heard from its main actors the commitment they have with this policy formulation that incorporates the needs of migrants. It is also pointed out that it is necessary not only to look at health services, but also to find ways to strengthen the capacity to address the social determinants of health, which certainly leads us to an issue that we will also surely discuss, which is multi-sectoral action that is required to address the needs of migrants and their host communities. Certainly, equitable access to care in particular, improving the quality of primary care appears as a crucial factor. In addition, not only financial protection of health needs, but also legal and social protection are elements that are frequently mentioned in the literature review. A particularly important issue is to reduce the information barriers that migrants receive and to establish round-trip communication mechanisms, so to speak, that are permanent and effective. Surely, in the second segment, you will be able to hear more about what are the critical aspects to improve the health coverage of migrants, and particularly about the systematic review that the Lancet has produced. And I think this conversation is going to continue beyond the seminar for sure. What are the critical processes to institutionalize migrant integration processes? It is a question that USAID's Comunidades Saludables program is determined to help the ministry answer with evidence. Certainly, financing, and we'll talk about that for sure as well. Financing of additional needs in a medium and long-term perspective, and that is always a challenge for our health system. Certainly, the political context and political will play a fundamental role in advancing policies and implementing them. The existence of data and evidence is also crucial to know if the policy is on track, if we are achieving the results, or if we need to make corrections in the course of its implementation. And I do not want to stop mentioning for the integration of migrants into the health system, a long-term effort of the entire community is fundamental. The participation of the receiving communities, of the migrants themselves, of the different actors of the community is fundamental. And so with these brief introductory words, I would like to invite Dr. James Fitzgerald, to whom I would like to ask two questions. What does PAHO consider to be strategic elements for the construction of public health policies for migrants? And we would also like very much if you could mention any experience to us that it has managed to respond adequately to the health needs of the migrant population that allows us to extract some lessons learned that may be relevant to the Colombian context. James Fitzgerald. Thank you very much, Midori. A pleasure to be with you again, and to the other panelists with whom I also have the pleasure of sharing this space. Above all, a very big thank you to the Ministry of Health, recognizing great efforts there to develop a comprehensive health and migration policy that responds to the needs of the population. As a starting point, I believe that this phenomenon, which was well mentioned by Dr. Escobar, is part of the regional context and is not a transitory situation. And given its complexity, it is necessary that we have a fairly fundamental look at its dimensions. There we have situations where we need to respond to the differentiated health needs of the migrant population beyond an immediate response, a humanitarian response, but also within the entire life course. And what really implies a much deeper reflection on a comprehensive policy on health and well-being within the migratory context. For us as PAHO, any health policy is based on the human rights approach. There we had in 2014 a complex but very important question about the concept of universal health and access and universal health coverage that really guide us in the creation of health policies in the region. Universal health implies that everyone has the right to health services that are comprehensive, with quality services without discrimination and with financial protection based on the principles of the right to health, equity, and solidarity. And there are several strategies that guide the implementation of strategies that have formed the basis, not only for the health policy of the vulnerable population, such as the migrant population, but also other policies and the processes of transformation of health systems in the region. And as you, Midori, mentioned well, it is important that we really maintain the approach of a vision of social determinants and the intersectoral coordination that we need. This has to address the living conditions, context, and environments that the migrant population lives in associated with these determinants such as water, access to water and basic sanitation, nutrition, education, housing, etc. Everything that we already know that has an impact on the health and well-being of individuals, the family, and the community. Here, I believe that the participation of civil society organizations is fundamental, community leaders as active participants in the construction of health policies on health and migration, and from this perspective, the long-term health approach during the course of a lifetime. You also mentioned the point that for us has been very important during the COVID-19 pandemic.
Important during the COVID-19 pandemic, and it's social protection. We have seen vulnerable population that is not very well integrated in the healthcare or social protection system, which is highly vulnerable to pandemics like COVID-19, but also any threat to their healthcare and well-being. In many countries, the migrant population is excluded, has limited access. There's transfer in social protection. Like, for example, migrant workers in the informal sector, they are people that are in labor precarity. And this has implication in regards to a lack of health, and they are at great risk for impoverishment. So there are barriers, important barriers with the initiatives that need to be addressed by any policy, not only from the point of view of healthcare, but also of social protection. So there is a technical element that we do have to consider, and it's about responding to the needs in the short term, but also during the course of life. And it's that we need a consensus, an institutional consensus about how we build and what are the fundamental elements based on the right to healthcare, to be able to develop healthcare policies for migrants. This also has to be translated into plans and programs for health based on the principles of access and a greater integration of other actors at territorial level to be able to be effective. This obviously means a very complex coordination, but effective, not only in its situation, but in the response to the needs. If you ask me about experiences, we have many, and some of them are complex. Now, when we talk about coordination, we've had good experiences, not only in Colombia, but in other countries of the region, like, for example, in Mexico. A big challenge that all the countries have is the interagency coordination. In Mexico, we have the Interagency Group in Health and Migration. It does comprehensive training of the healthcare staff, tending migrants, and looking at epidemiological surveillance, but also the health services. Another example is when we talk about the services network based on primary care that has the capacity to increase its capacity at any moment, but also maintaining quality and service provision both for the population that lives in the area as well as in migrants. Here we have examples that surely you know in Colombia because you have a lot of experience in this, because it's a border area with Venezuela, but also with the Amazon. And there's other experiences that are a little bit more complex that we have not seen, or we have seen between Haiti and Dominican Republic, recognizing the inflow of people in these areas, which are really not well tended. The other example that we maybe have to think about is the legal aspect, the legal protections that once we have defined the policy that is translated into legal and legislative actions and decrees, we had very good experience, for example, with the Central American Parliament, with the migration laws, and I invite everyone to go read that law because of the content that is now guiding other national laws in the Congress for all the Central American countries. So these are some of the examples. There's others on mental health that we could mention also, but I think I'm going to be stopping here, Midori, and we hope that in case you need more clarification, we can ask questions. Thank you. Thank you very much. Thank you very much, James. Very interesting. And we know of the great work of PAHO in putting this complex topic in the agenda of all of the countries, and we thank you for that. Also, we now bring Dr. Alexander Adnikov. As we know, he knows the phenomenon, the migration phenomenon perfectly in his experience in the International Migrations Organization and in his work in the region specifically. Thank you very much for your participation. I would like to ask you the same questions, Dr. Adnikov. What do you consider are the strategic elements from the point of view of IOM for the construction of public policy that we have been talking about that allow integrating migrants into the countries and the receiving communities? And if you can share with us maybe an experience that you have witnessed that you believe can serve to extract information for the Colombian case. You also have 10 minutes. Yes, thank you. I'm sorry, my presentation is going to be in English because most of the material I have is in English.
Thank you very much for the opportunity, giving me the opportunity to participate in this webinar and present few aspects of Yes. Yes?
Yes,
Is it okay? Can you hear me?
Yes, we can.
Yeah,
okay. Okay. So I will present few aspects of IOM's approach to migration and health. So we can start the presentation. Next slide, please. I will briefly now explain the IOM's concept of migration and health and the health policies. Next one. Okay, so the main approach of IOM to migration and health is organized around four priorities, and these are monitoring migrant health, policy and legal framework, migrant-sensitive health system and partnership systems, and partnership networks and multi-country frameworks. Using this approach, we aim to ensure the standardization and compatibility of data on migrant health and support the appropriate aggregation and assembling of migrant health information. We intend to map the good practices in monitoring migrant health, policy models, health system models, and this goes through the key priority that is called monitoring migrant health. Through the policy and legal framework, we adopt relevant international standards on the protection of migrants and respect for rights to health in national law and practice. We implement national health policies that promote equal access to health services for migrants, and also we try to extend social protections in health and improve social security for all migrants. The third aspect is migrant-sensitive health systems. There is a priority focused on ensuring the health services that are delivered to migrants in a culturally and linguistically appropriate way. And also we try to enhance the capacity of the health and relevant non-health workforce to address the health issues associated with migration and to deliver migrant-inclusive services in a comprehensive, coordinated, and financially sustainable fashion. Finally, through the last priority, we establish and support migration health dialogues and cooperation across sectors. among large cities and countries of origin, transit, and destination to address migrant health matters in global and regional consultative migration, economic, and development processes like the Global Forum on Migration and Development, for example. Next slide. So the health promotion and assistance for migrants is a program area of Migration Health Division of IRM that caters its strategy and activities to the needs of migrant population and the changing requirements of member states to address the health of migrants. So IRM projects in this area provide access to high quality health services for migrants and undertake a substantial amount of operational research to promote evidence-based migration and health policies. So the technical support and national capacity building efforts are included in this work area to support member states in efforts to better manage migration-related health challenges. This program area covers a range of health topics, including emerging and re-emerging infectious diseases such as influenza, tuberculosis, malaria, and sexually transmitted infections, including HIV, as well as non-communicable diseases and health issues such as mental health and psychosocial response, reproductive health and occupational health and safety. Overall, these activities facilitate the strengthening of migrant-friendly and migrant-inclusive health system, which benefit migrants and the communities in which they live. Next one. Thank you. So all the programs and interventions are focused on a wide range of beneficiaries, and these include and are not limited to workers, undocumented migrants, trafficked persons, seasonal and otherwise temporary cross-border migrants, and internally displaced population and migrant communities. We also pay special attention and have programs for those who are more vulnerable or are in vulnerable situations, and these include women, children, ethnic minorities, and people who lack resources. Also, there are many programs that cover non-health topics in the context of migrant health, such as gender, sexual, and gender-based violence, climate change, and human rights, among others. With our partners, we seek to provide as comprehensive and as diverse as possible interventions, so to make sure that all the aspects of migration and health are covered. And this includes our latest memorandum of understanding that we've signed with PAHO recently to support the provision of comprehensive, quality, and equitable services to migrants in the region of Latin America and the Caribbean. Next one. Yes, IRM has three major lines of intervention to secure that migrants' health aspects are addressed. This is health assessment programs that are more medically oriented, medical approach, but we don't have this type of programs in the Americas. Then we have the health promotion ones, and these are the more public health oriented projects, and then the emergency. The public health line, has a very rich portfolio of diverse programs, and these are some of the selected few ones that I want to share with you. Next slide, please. So, to name the few, EquiHealth, that is implemented through our regional office in the European Union in Brussels, and this aims to improve the access and appropriate healthcare services for vulnerable ethnic minority groups like Roma population in the European economic area. Then PAMESA, I will talk a little bit more in details about this one later on. Then another one that is really notable to mention is TB Reach. This is a project that goes across countries like Cambodia, Ethiopia, Ghana, Laos, Myanmar, Nepal, Thailand, and this program is specifically created to ensure timely and complete treatment and high TB cure rates for those who have limited access or no access to TB services. Middle East that covers the challenging operating environments like Yemen and Syria and provide preventive, diagnostic, and therapeutic services on HIV, TB, and malaria. And the last one that I will briefly also describe is electronic personal health record. So let me explain briefly the two projects that I want to share with you. Next slide, please. PAMESA. PAMESA is Partnership in Health for Migration for Migrants in South and East and Southern Africa. And this project was funded by the Swedish government and was implemented for almost 11 years. And through this project, we reached thousands of people in 9 countries in East and Southern Africa. Initially, it was developed as an HIV project, and it evolved in a program that addressed health concerns that particularly affect migrants and mobile populations, with focus on HIV prevention, treatment, and care, and related conditions like TB and reproductive health. The whole program was organized around the 4 key priorities: research and information dissemination, advocacy and policy development, service delivery and capacity building and partnership, and it was focused on labor migrants and mobile workers, forced migrants, and irregular migrants in the context in which they live and work. So why have I decided to present this project? Because its comprehensiveness and scope that was huge. We managed to influence many policies in each of the countries that were part of the project, and we developed tools to influence these policies as well. Then we managed to provide huge range of community-based services with massive involvement of the host communities, worked with local authorities, community leaders, religious leaders. We worked in long migration corridors and transportation corridors from Congo to Mombasa in Kenya, and from Dar es Salaam in Tanzania to Cape Town in South Africa. And these are thousands of kilometers to provide continuity of treatment and services for truck drivers, for example. So we work directly with the national systems on the local level. We made so many adjustments and changes to transform them in migrant-sensitive services. We also intervened in many existing national data collection systems. This is exceptionally important. There are health and non-health, including the census in some of the countries, to include migration-related variables, etc. So I specifically use this example because with this project, we established the basis of the public health approach of IOM to migrant health in 2004. So it even inspired the 2010 Global Consultation on Migration Health organized by WHO, IOM, and Government of Spain that laid the foundation on the public health approach to migrant health and the 4 key priority areas that I explained at the beginning of the presentation. I will end this presentation with the next slide. Thank you. And this is another project that to me has a huge potential, and I want to present to you, and this is electronic personal health record. And again, why I decided to present this project? Because this is an innovative and contemporary approach to continuity of treatment. And this project is a branded tool of IOM that has recently been listed by the UN Secretary General as one of the tools that contribute directly to sustainable development goals. So it was initiated first in few countries in the European Union along the route from the Middle East to Southern Europe, Greece, Macedonia, rest of the Balkan countries, all the way to Germany. So it is a health record system that is cloud-based, and it stores the data of all the migrants in need for health assistance. So when a doctor at the entry point in European Union, for example in Greece, checks for the first time a migrant coming from Syria, will enter all the information about the health condition of the migrant, all the tests, lab findings, x-rays, digital images, diagnosis, treatment, name it. So when the same migrant from Syria reaches its final destination in Italy or Germany, the doctors there will know what the health needs of this migrant are. But not only them, also the doctors in the transit countries, like in countries in the Balkans, will be able to assist the same migrant on the way to his final destination in Germany or Italy, for example. So some countries like Italy are seriously considering adopting this system as a national system, even for Italians. So a patient from the south that if moves to the north will probably be monitored and taken care of by the health system. I honestly think that the next region after European Union, where this project can be implemented, is South America. I already presented this project in the Ministry of Health of Colombia, and I hope that we'll move on with the negotiations. But for this, we can discuss a little bit later on in some other occasions. So that would be all. Thank you so much for your attention, and looking forward to receiving your questions during the Q&A session. Thank you.
Thank you so much. Muchísimas gracias, Dr. Adnikov.
Thank you very much, Dr. Adnikov. It's very interesting. We had to have here the topic of digital transformation and the support of these integration efforts of migrants in receiving countries and their communities specifically. I also think it's very important to highlight citizen participation and the participation of civil society organizations. It's indispensable to support, we believe, the formulation and implementation processes for policies with effective channels, comprehensive, of voice of citizens, of voice of migrants. Thank you very much once again. And now I have the pleasure of talking to Dr. Julian Fernandez. He has a lot of experience in Colombia with the migration phenomenon. And I would really like to be able to ask him a few questions in regards to what he considers are those fundamental elements that are strategic in the Colombian case to drive a policy that is integrating for migrants that you have received very generously and that the region is very thankful for. Good afternoon, everyone. Thank you, Doctor, for your invitation and for the question. I hope you can hear me fine because we've been having issues in the connection, with a connection in the ministry. I think you're hearing me fine, right? I think we have to start with an important reflection, and it's that right now, and after 3 years of the migration phenomena, the mass phenomena from Venezuela, this has existed for many decades. And Colombia is nowadays a reference in the world in the response and the way that we have included the migrants. Of course, everything is insufficient when we compare to the vulnerabilities, the needs of healthcare, but it's important to put them into context of the capacities and the starting point of a country that has mid-level income like Colombia. We are talking about the fact that Colombia really quickly structured a response plan for the healthcare sector for the migration phenomena that guaranteed the guarantee of ER services for all migrants regarding of their migration status, their pregnancy checkups, delivery care. This effort has also been with the cooperation, with the articulation of international cooperation. So we have learned the lessons from the countries, and I think this is the moment when Colombia can start talking about what they have done. What's the challenges of the inclusion of migrants in the healthcare system are a lot. First of all, the healthcare policy and healthcare services have to be part of the regulation. We currently have approximately 1 million migrants. And as we have contemplated the policies in the healthcare system, we cannot ensure these migrants that are not permanent. This is the migrants' vulnerability. Migration is not a cause of bad health. Migrants giving their labor informality and their low income and their living conditions have a high risk for health. Third place, the high mobility that migrants have determines that it's hard for them to do traceability and follow up from the healthcare system. When I talk about mobility, I don't talk about transit, only pendular. I'm also talking inside the country. The healthcare systems are conceived to tend to fixed populations. So for healthcare systems, it's a challenge to care for pendular populations. And the emergency models are conceived for responses for contingency for short term. So the Colombian phenomena is a challenge of different types of mobility. It's not the same healthcare needs for migrants that are permanent than those who are pendular and those who are in transit. After having explained these challenges, we've made an effort so that we can progressively guarantee the rights to healthcare of migrants. And this can surely be guaranteed gradually and according to the capacities, keeping in mind that we're talking of more than 2 million people, only talking about the permanent migrants. For us, it's necessary to move from a model where international cooperation is based on emergencies to a model based on institutional strengthening. It's important not to generate new inequalities or fragmentations of the healthcare system, but now we're going to have a graduality in the inclusion of migrants in the healthcare system, given the system's capacity, given the needs to explore funding. But our North Star has to be the guarantee of the right to health of migrants in the same conditions than any other resident in Colombia. This happens when we want to build healthcare migration policy, but beyond that, we need to see how we can guarantee the inclusion of migrants in policies, not creating new responses that are alternative for migrants, but including the migrants in the policies that we already have. So more than migration policies, it's migration of the policies is a step to inclusion. Now, the right to health is determined by the effective access to the rights to health, but also to social determinants. So, as migrants are integrated socio-culturally and economically, healthcare is also going to improve. That's why, from a perspective of social determinants, it's not possible to guarantee the right to health without reducing the inequalities and without guaranteeing the acceptance, cultural acceptance, and reducing, of course, the gaps and xenophobia in this moment. I will now end. I've said that I'm going to finish twice, but now I will finish. Calling to your attention of how the response to COVID in Colombia is an example of the valuation of the right to life and to healthcare that Colombia is doing of migrants, regardless of their migration status. They are included in the press. They have the right to the service or emergency service care. There is a guideline for the access to tests, and we have guaranteed their inclusion in the response to COVID because it's not possible to respond by distinguishing nationalities because the virus does not distinguish nationalities. So we have done this with Colombia's response. We now hope to advance a lot. We are waiting to see alternatives for funding for healthcare, especially in kids younger than 5 and pregnant mothers. We are planning this with both vice ministries, the growth in the public healthcare actions. And now we invite you on December 2nd. Let's see if I can turn on the camera. We invite you on December 2nd, 9 a.m. It's going to be online and to the launch of the National Plan for Health Migration. It's a great effort to gather information and to generate knowledge management so that international agencies and, of course, the migrants can be advocates for their rights and get to know the healthcare situation of migrants. Thank you very much. And I hope you were able to understand me with my difficulties, my technical difficulties. Thank you very much, Dr. Julian Fernandez. It's very interesting to hear about the Colombian experiences, and as you're saying, a lot of lessons for other countries in the world, particularly countries from the region. I have a question here that is very interesting about something that we could not leave out of this conversation, which is funding. And it's a question for the three of you, actually. Certainly, incorporating growing and significant numbers of migrants within the healthcare systems puts pressure on the limited budgets and the scarce resources, as they have always been for healthcare. What messages could you give us in regard to funding, particularly in the framework of universal healthcare coverage? I would like to start with you, James. Thank you, Midori. It's a great question. So if we talk about the context of funding of healthcare systems right now in the region, on average, the public expense in healthcare is around between 3.8 and 4.2 of the GDP, which is way below the numbers in countries that were adopted in 2014 and the reference countries in OECD. And I understand that Colombia references that it's 6% now. We also know that it's a progressive process to be able to increase the investment, the public expense in healthcare. I'm saying public expense because this is the most equitable way to be able to respond to the healthcare needs of the countries, especially considering vulnerable populations. We also thought that if we really want to increase funding, this should be with inclusion, because this will be more efficient and more effective to respond to these needs. And additionally, doing this, we avoid the expenses associated with to delays in seeking healthcare, which results in very high expenses in hospital charges. So this should not be considered an expense, but an investment. The investment in people, investment in social and economic development. But we do recognize that it's a very big element. Another element here is associated to the expenses. As you know, this is very high. And this is associated to a low level of public investment in the countries. But the problem is that this is highly representative and can result in impoverishment. And when we were talking about populations like the migrant population, this would be catastrophic. So maybe we would have to see this in a different way, like an investment on people, on social development, and recognizing that everything needs to increase the investment in general. Thank you. I would like to link these responses to something that's very important that Dr. Julian mentioned, and it's avoiding these temptations that we sometimes have of creating parallel programs, vertical mechanisms, and things that are not really integrated in the operation of the country's healthcare system. They seem to be very effective in the short term, but we know about the distortions introduced in the systems when we create these vertical programs. I don't know, Dr. Julian, if you can tell us a little bit about this decision of the Colombian government and the Ministry of Health and Social Protection of safeguarding these ideas of parallel programs related to funding in particular. The migration phenomenon from Venezuela and Colombia but there's cases that are not as visible and have lower volume, but they have the same importance. Sorry, this person is having a lot of issues with his connection. There's 2 million people that are permanent, almost 1 million in transit, and between 3 and 5 that are pendular. Second, and third, because Colombia is a country with mid-level income, with the migration compared to countries with low income, this would seem to be that the efforts have to be assessed in the context of the country's capacities, the country's context, and the capacities of the phenomena. In a first instant, it made a lot of sense, like in the pandemic, to have responses based on emergencies, humanitarian responses. But when we are talking about more than 3 million people, we need to move from emergency-based responses and mobile units that I'm not saying they're not important, but we need to go towards institutional strengthening that has to be long-term. Like, for example, surveillance and public health, not only for COVID, but for all the interesting events in public health, to include migrants with strategies of community surveillance. How do I integrate migrants to primary healthcare services? We need to highlight that Colombia has done a great effort this year with the decree, the affiliation decree, where they put the 7.3% of the GDP for healthcare, where they allowed affiliation for regular migrants, ex-combatants, and this is a strategy that has great potential to increasing the fact that regular migrants can access to this kind of insurance. Of course, the great challenge is the irregular challenges, the irregular migrants, the pendular migrants, and the migrants in transit. The healthcare system is not easily designed to serve them, but in the case of permanent migrants, we need to think about long-term responses. And from the ministry, we're exploring alternatives for funding to be able to guarantee basic care, especially for kids below the age of 5, for pregnant women, and for the elderly, which contribute the large part of the burden of disease in migrants. Fortunately, most migrants are relatively healthy. It does not mean that they don't have any healthcare needs, which is different than health issues. There's a long way to go, and I want to emphasize that many of the determinants of the right to law are outside of the healthcare sector. We need migration policy that favors regularity more than regulations, and policies that promote economic labor inclusion as determinants of health. Okay, and a question that I got on the chat that I thought was very interesting related to mental health. It says, given the vulnerability issues because of a lack of regulation and cultural shock and xenophobia, what is the role of public institutions in healthcare at any government level, meaning national, department, or municipality, of mental health care services? What experiences can you talk to us about in policies that have emphasized on this severe healthcare issue caused by leaving your home and all the situations that you have commented today? Sorry, Midori, I don't know who the question is going to, but maybe I can comment. What we have in regards to mental health, we don't have to see this individually, but in regards to the holistic needs of the person, which of course has an specific and differentiated needs in this aspect, but recognizing the conditions of life that they are in the context during their migration process. I think there's some experiences that are very interesting on the topics, and what we can talk about is the difference in Brazil with the integration of mental health services in network services based on a care provided by multidisciplinary professionals and teams that face all the healthcare needs and that have reference and counter references to all the levels of the system in public health and to all the services in this area of the population that have actually incorporated mental health care services at all levels. So again, as Dr. Fernandez mentioned, the integration process to programs in the healthcare service that really helps us to offer or to assess all the needs of the population.
Also, if I can add to this, supporting the health services and including the psychosocial support services to become migrant sensitive and migrant friendly is also one of the options that can help providing better assistance to migrants. And this means in a very big sense of changing and it's a big job that is ahead of us. Changing the mindset of the people that are included in the health system, even those who are providing the services directly. So basically, sometimes it is a case when the migrants are receiving all this xenophobia and stigma attitude towards them, even from the people included in the health system. Therefore, and providing the services. Therefore, we have to start from the starting point should not be only the health system itself, but also across the different areas of the health systems, including capacity building and changing the mindset and sensitization of those who are involved directly in provision of health services, and as well communities. So adjusting the communities and health services to migrant needs, more or less, or explain what are the migrant needs in order for us to develop migrant sensitive services may be the good option. It may be a good option for achieving the more comprehensive and equitable healthcare and service provision.
Dr. Adnikov, you have made us remember about looking inside the healthcare system and within our healthcare services to be able to develop the skills and capacities of our own healthcare staff to be able to tend to migrants and their specific needs, but also improving the quality for healthcare services for the communities in general that receive the migrants. And this is once again related to how to extend the benefit in the community, and in particular to the communities that receive their migrant brothers. There is a little time left, and I do want to share a question that's very interesting that I got also, that made us look towards migration as what it is, a phenomenon that crosses borders, not only from one country to another, but also in the specific case in South America, it also crosses several countries, as we know. The Venezuelan migration phenomena has reached almost all the corners of the South American territory. So the question is about reflectioning on what multi-country mechanisms from the perspective of PAHO, IOM in Colombia, that actually has been working on this a lot. What would be the mechanisms that could be effective so that the efforts are not only of one country, but a coordinated effort at regional level? What institutions do we have that could help us do this? What are the fundamental elements to be kept in mind in a cohesive, a multi-country policy? Maybe we should start with you again, Dr. Adnikov.
Okay, so in order for us to be able to provide a proper regional response, we need to activate all the existing regional instruments and bodies. For example, we have few in the regions of Central America and South America and the Caribbean, for example, the INCOSAMI, that is the Iniciativa Conjunta sobre Migraciones in Central America, and also, for example, Organismo Andino de Salud in South America, CARFA, Caribbean Association of Public Health in the Caribbean, obviously. So using all this coordination and existing instruments and bodies in order to align their policies with the guidelines and approaches that both agencies have. Like I can speak on behalf of IOM. That would be one of the first steps that we need to do, because otherwise, especially nowadays after coronavirus, the pandemic, and during the pandemic, we realize actually that the funding is really limited, and especially in this region of the world. So therefore, we need to be investing our time and energy more in the regional coordination in order to have a better distribution of funds available and resources, including human resources, so we can distribute better responsibilities and achieve more in terms of migrants' health. Therefore, I would start with all the existing coordination bodies and networks, and build even more. There is nothing wrong if we are more connected.
Thank you. Now, James, just to complement. Yeah, can you hear me? Yes. Okay, so just to complement what Alexander's saying, in PAHO context, we have the governing bodies of PAHO, WHO, where we have regional healthcare policies and strategic plans that correspond, where all countries participate. A Ministry of Health comes from Washington every October to look at these mandates. There's a limiting factor in the context. And we have mentioned at first, this is to respond to the other dimensions in the migration context. And for this, we signed an agreement with IOM, with Alexander as the executive president of OIM, and Dr. Jean, so that we could work with all the sectors interinstitutionally and promote intersectorial coordination to be able to improve the capacity in regards to the integration mechanism that exists in the region. Thank you. Thank you, James. Dr. Julian, I would like to hear about your reaction from the perspective of the Colombian experience about these interregional and multi-country agreements. What do you think is we need to do in this space? Can you hear us, Dr. Julian? I don't know if Dr. Julian can hear us. Yes, I'm here. Thank you. We know that you're suffering a little with the connections today. Yes, I would only compliment you. Can you hear me? Yes, you can hear me, right? Yes, we can. I would only compliment by saying that the experience of response of the healthcare sector to the migration phenomena is right now a model for the world, because I believe that given the volume of migrants that we have had per unit of time that has been so high, at least from the regional perspective, Colombia would have a lot to transfer of its experience to other countries in South America in regards to migrants. I believe that creating agreements for migrants based on a human safety optic is something with which we can have stronger multinational agreements, particularly thinking about the people who are in transit, like shared responsibility among the countries. Colombia holds the greatest majority of Venezuelan migrants. And they are the ones that have the greatest vulnerability socioeconomically. In that sense, I believe that Colombia has faced, in certain aspects, a part of the challenge, and that it's necessary not only to have the support of international cooperation, which has been vital, but also the support with coherent inclusion policies for migrants. Thank you very much. It has been a very rich conversation. We have talked about a lot of different topics, and I'm sure there will be part of the conversation of Block 2 this afternoon. And we once again want to thank Dr. Fitzgerald, Dr. Adnikov, and to Dr. Julian Fernandez, that we know is very busy. So our appreciation to the three of you, and here's where we say goodbye to Block 1. Have a good afternoon. Midori, thank you very much for your help. Thank you very much to all the panelists for the reflection that you shared with us today. We do have to delve in the learnings and successful experiences of public policy and health in regards to migrant population. And now our next section is called Lessons Learned and National and International Experiences in the Search for Inclusive Policies in Healthcare and Social Protection. Again, remember that some of the presentations can be in English, so we recommend you have the translation service available. This is going to be moderated by the Vice Minister of Social Protection of Colombia and Ms. Maria Andrea Coroy, and we will have Ietza Borges, researcher of Colegio de la Frontera Norte, Dr. Michael Rodriguez, Vice President of the Family Medicine Department of University of California, Dr. David Engelby, senior researcher in the Social Sciences and Global Health Center at the University of Amsterdam, and Dr. Miriam Orkut, researcher and executive director of Lancet Migration. Vice Minister, the floor is yours. Good afternoon. First of all, I want to welcome Good afternoon. First of all, I want to welcome you and I want to thank all of you who are here in this panel, Lessons Learned and National and International Experiences in the Search for an Inclusive Policy in Health and Social Protection. For the Ministry of Health and Social Protection in Colombia, this type of spaces for exchange with international experts are fundamental to improve our response to the migration phenomenon based on the lessons learned and the successful experiences. Colombia shares 2,219 kilometers of border with Venezuela and has been a witness of the mass exodus of Venezuelan citizens since 2017, when, according to the numbers from Migración Colombia, close to 430,000 migrants from Venezuela came in. And in 2020, it's 1,748,000 as a consequence of the economic and social crisis of our neighboring country. In this humanitarian crisis situation, Colombia has generated immediate response capacities to be able to respond to this migration phenomena, like the creation of the regularization process for the migration status through the special permanence permit. From the healthcare sector, we have sought to guarantee, as ordered by the law, the fundamental right to healthcare. And based on very big efforts as a country, we can now say that we have been able to ensure more than 337,000 Venezuelan migrants. Unfortunately, factors like high mobility, lack of information, and the loss of payment capacity of these people have made us today have 52,000 of these migrants that are not affiliated to the system. And that's why by October 31st, 2020, 285,842 Venezuelan citizens that are identified with a permanence permit are in active status as affiliated to the healthcare system. Even though this is an advance and a progress, this gives us a huge challenge of being able to increase this threshold of 40% coverage to the population that is regularized. Colombia has characterized by doing great efforts in regards to the guarantee to the fundamental right to healthcare. And that's why, additionally to the affiliation of the general system of the regular population, our regulation contemplates the access for the more than 850,000 migrants from Venezuela that we have found that are irregular. The assurance of health provides the greatest guarantee for the services to the population that is affiliated. It gives them financial protection for all the residents in the Colombian territory in case of determining, and it allows having a timely and quality service with services of promotion and maintenance of healthcare and prevention of disease, as well as the access to collective interventions and extramural interventions. However, Venezuelan migrant population requires a series of services that many times is not possible for them to access to them, considering the condition of most of them as pendular populations. Keeping this in mind and the healthcare model, our healthcare model, together with the difficulties in regards to regularization, has generated important pressure in the funding mechanisms of our healthcare system because even though the ER services are free for patients and for users, these resources, as I was saying, need to be borne by the local governments and in counterpart with a national government that bears other resources for assurance. This makes this breaks the resource planning exercise and therefore leads to an increase in the debt with the public hospitals that are providing the services to Venezuelan migrants. The international experiences have shown us that one of the first sectors that is impacted by migration is the healthcare system, and for the Colombian case, this has not been any different. One of the greatest challenges has been the adaptation of our healthcare system in all senses, in human resources, in technological resources, in information systems, in in regulations that have had to be developed to be able to respond to this phenomena. But at the same time, we require a socio-cultural adaptation of the migrant population to the new context and the requirements to be able to overcome part of the social determinants that are affecting them. This is why we consider that today we are before a double adaptation exercise, adaptation of the receiving state, which is us, and the migrant population. And this demands necessarily the acknowledgement of a co-responsibility process where both the rights and responsibilities of each one of the stakeholders, the institutions and migrant population, need to be fulfilled to be able to have a real integration of the population into the Colombian healthcare system. In this landscape of recent learning that our country has had, and in the response to migration phenomena, we see the exchange of experiences and exercises as a great opportunity with countries like Mexico, Greece, and the United States. Likewise, we are convinced that the tools applied in the world, like MIPE, can offer important approximations of follow-up in regards to public policy directed to migrant population. So this is the reason why I welcome this wonderful group of panelists that is here with us today to be able to do an exchange of all these experiences that they have had in the different countries that I mentioned, talking about the migration phenomena. Dr. Ietza Borges, Dr. Michael Rodriguez, Dr. David Ingleby, and Dr. Miriam Orkut. We start with Dr. Ietza Borges. From her experience that she has obtained as researcher in the Department of Population Studies of Colegio de la Frontera Norte, we would like to ask you, what is the status of the healthcare policies for migrants in Latin America? Thank you very much, Vice Minister. Thank you to the organizers of the event for the invitation. It's an honor for me to participate as a member of this panel with colleagues with such great trajectory in this topic, so it's a pleasure to be with all of you. To respond really quickly to the question of the Vice Minister, I want to say that most part of the countries in Latin America, in reality, have, at least on paper, healthcare policies for migrants that are relatively inclusive in the sense that almost all of them recognize healthcare as a right that is independent of the migrant condition. Now, from that to actually implementing the policies, that is where we have the greatest gap and the greatest difficulty, probably. Almost all the countries in Latin America, in the access to healthcare for all the migrants that are regular or that are refugees, is given in the same conditions that the rest of the population that is in the country. But in this sense, there are certain barriers that can be faced. First of all, we have a series of administrative barriers that sometimes are explicit and sometimes are given in the everyday practice and that are related to the need to present documents that are sometimes harder for migrant population even if they are regular. It's harder for them to obtain these kinds of documents. Or other types of conditions like history, having an address, and it can be even harder for migrants to fulfill. So maybe what we are needing the most in our countries is considering the need of adapting certain procedures, making them more flexible to be able to facilitate the situation of these people considering their specific conditions. On the other hand, in regards to irregular migrants, the situation in general is that the access is very limited. Generally, they're only seen in the ER and in special populations like pregnant women or children, or they are included in public healthcare actions, but the access to the services is not complete. And in this sense, it's a population that can be actually large in different countries that is actually, or basically not protected. So from this point of view, the first action or the most important action to be able to guarantee the access to healthcare services for migrants in our countries in Latin America is related to facilitating these regularization procedures. As a migrant or as a refugee, no matter your condition, to be able to facilitate the access to healthcare services. And another option also that some of the countries are considering is that not actually requiring a regular condition to be able to have access to the service, but there's universal access by anybody who is in a country's territory. The challenge is maybe how this universal access is really reflected in practice. And this is very much related to the resources that you have been mentioning and the funding. And we have these two types of situations. One in which we require a series of steps and procedures that are administrative and documents for regularization to be able to access to a service, and others in which at first you don't need them, but we're not really clear about which one of these two systems work better in guaranteeing coverage, and what are the weaknesses and strengths of these types of systems, which I feel is very important to continue investigating. And on the other hand, in any of the other types of systems, migrants can have barriers to access that are similar to those of the population that are not mobile, but that are low income. And as we all know, given the financial difficulties of the healthcare systems, the systems that care for people without any social security or in general low-income people have a lot of limitations to be able to give effective coverage, full coverage. So in this sense, as many of the migrants are in this situation, they have low income, they have irregular employment, even if they have their migration conditions regularized, they are in this situation of a difficulty to access that at the end means a pocket expense that can be 50%, up to 50%, depending on some of the countries of Latin America, or even higher. So the barrier becomes a common barrier. That's the issue of the healthcare system as a whole. And I want to mention that in this sense, even if there's big differences because of the volume or number of migrants or in mobility between the different countries and the temporality where these phenomena happen, like for example in Colombia, there was an inflow of a large number of people from Venezuela in a very short time. And in general, in our countries, the number of people who go into the country are relatively low compared to the local population, and given that we're talking about relatively young and relatively healthy population, the financial burden would not be that high, except in certain areas, and of course there's different situations, but trying to paint a broader picture, this is important to be considered. Thank you. Thank you very much. We also have a doubt or a question for Dr. Ietza, and it's what's the status of the healthcare policies and strategies for migrants, specifically about related to the border zones? Yes, thanks for the question, Vice Minister. I think that we also have to point this out. I talked about a general overview of the countries and the region. However, there are special areas where we concentrate migration inflow both in transit or people who are requesting for asylum, and people who are in permanent or semi-permanent border transfers. They are the regions or municipalities that have a big burden in this sense, and that's where we should really be concentrating these resources and this planning, because it's in these areas the ones that should have the possibility of having a faster resource management, because if we have very centralized planning, we don't really recognize this. Another situation that happens in these areas is that there is where we can have situations of humanitarian crisis, as what we have seen in our borders, even more so from the beginning of the pandemic. So this humanitarian crisis situation needs a fast management, and it needs to be different than the mid and long-term inclusion of people that are in mobility in the country's healthcare systems. But at the same time, we need to be careful that this representation of the problem as a humanitarian crisis does not make us forget that there's this other huge problem of the people. Um, and I think it's very important, the term that you use, people that have like a vocation of permanence. And these mixed flows, the individual experience of those who are part of the groups makes it very hard to classify them as asylum requestants, transit migrants, displaced population. One same person can have several of the conditions at the same time and change their migration project along the way. In the border between Mexico and the United States, where we have been observing in the past years the situation of people who are coming mainly from Central America with the intention of going into the United States, and that have stayed trapped in the border with Mexico because they cannot go into the United States, and they start changing little by little their idea of their life project, and they leave the idea behind of going to the United States and start to look alternatives to stay in Mexico. And in this sense, for the border areas of Mexico, little by little it turns, or it goes from an emergency, humanitarian emergency situation to an integration situation. We have to start thinking about the policies for these migrants, because in Mexico we didn't used to think about that before, because we used to have a very small number of people. So these situations are very specific, and I repeat, I think that here we have to see what the relationship is like between the local government levels and the higher levels up until the federal level in Mexico and in other countries, and the speed at which we can handle these relationships so that the resources flow, so that the needs are satisfied, and that we don't have these dramatic situations that we are living in our region sometimes. Thank you. Thank you, Doctor. It's very interesting, the topics that you are stating from the point of view of these gaps that are generated between the systems that on paper are saying there's universal coverage, but at the moment of actually having effective access to the services, there's a big distance in the possibility that the migrant population has of being able to actually effectively provide the service, as well as from the countries that are receiving this population. We live all of these financial hardships, but sometimes we don't consider this that you're explaining very interestingly, which is the characterization of this population. It's a population that, as you're saying, is relatively young. They maybe doesn't have the same burden of disease like other kinds of populations that are already in our territories. And this is the way in which we should focus the problem, to be able to obtain these resources and look at possibilities for funding. The last thing that I think is very important is looking at the border areas, as you're saying, when we went from the measures of humanitarian crisis to inclusion policies, to be able to give them the adequate attention and incorporation to society as should be. Thank you very much, Doctor, for your contribution. And now we go to our second panelist, Dr. Michael Rodriguez, to ask him what has his experience been through teaching and as a director of the center that you work with, which is about poverty in Latin America. What have these inclusive policies been like for migrants in the United States? Okay, good afternoon, and thank you very much for the invitation. Thank you for the Minister of Health, the Vice Minister who's here with us. Thank you to all the other panelists, including and especially Dr. Borges, who I follow and makes my work, my job so much easier or harder at the same time. So first of all, I want to recognize and as we have been talking about, this is a very complicated topic. We need to recognize the different challenges or some of the different challenges that we face in the Americas, like inequity. I'm not going to go into detail, but just to acknowledge this, the different inequalities in healthcare, as well as in other areas, the complexity of the policies, both polarization, violence, and corruption. You can read the details here. And simply, I say that the United States participates in all of this also. The triple disease burden, weakness in governability, climate change, population aging, and today's focus, which is migration. Do I have to move my slides or will somebody else do it for me? Okay. Several of the panelists have mentioned this, like this term health determinants. And this is a diagram for health determinants. I put this here as a reference. Many of us in medicine focus on the individuals or the individuals' lifestyles, and we don't really go to the factors that really have a greater impact on healthcare, which is important when we are talking about the factors that affect the health of populations, including migrants. This is something that focuses a little bit more on migrants, knowing that community and social networks are very important, including topics like social inclusion, and also, as you see here, education, work and life conditions, and socioeconomic, cultural, and environment conditions, as well as discrimination. This is aligned with the Sustainable Development Goals that have been mentioned before. Just to recognize that this is another effort that we are carrying out worldwide. Most, if not all, of the different goals are related to health. And of course, the environment is very important for health. These are some pictures or images of conditions that we see very commonly in different parts of the Americas, as well as the behavior of the labor market and how this is linked to poverty, both to generate employment and to have better salaries and the creation of better quality jobs. Also, education, which is another very important topic. And here, I wanted to pay attention to the macro determinants, which has an influence on all the environment, including the influence of globalization on the social, economic, and cultural conditions of the countries connected to what Dr. Borges has just said. In the United States, we are facing, or we have been facing, social conditions that are really hard in many of the different immigrants. And this is part of this context and environment. There are a lot of different research that has documented that the access to health and different examples of health are actually worse for migrants in comparison to others that are not migrants. Paula teaches about the use of healthcare and problems in getting healthcare services, and several others in this topic that is very well known. But what we don't really know a lot about is how policies have an influence in immigrants' health. The policies that shape personal and direct experiences that the immigrants find with the different ways and applications of the law of immigration. And here we are talking about policies related to health determinants. We are now doing a study that's called the RITS. It seeks to understand how the immigration policies of California shape health, because the policy migration policy is a social determinant. It has an influence, or it can have an influence, on experiences of exclusion and inclusion, and this can affect the usual medical care source and delay care in general. The different sectors here we see the different areas that we are looking at and studying in regards to policies. They're not all focused on healthcare, like access to services. I don't know what's going on here. Maybe it's a ghost, but let's move forward. It's access to healthcare and also social services, like being in programs for food and lodging and education, including help for education, like scholarships and other kinds of help to be able to attend to university education, employment, and how we protect against the stealing of salaries, or how to take care of labor decisions. Also, the execution of immigration and being able to obtain driver's licenses, or running into the immigration system, which is what usually happens. These are all different systems where there are policies that can be protected and they can work to be able to help include or exclude immigrants. We did a study looking at the different areas, seeing which ones were the states in the United States that had the greatest number of inclusive policies and others that have the least, to be able to help us see what the context is like in the country, in the United States. And as you see in this map, the colors reflect the amount or the number of policies, inclusive policies, that the states have currently. In dark green, representing more inclusive policies, and the orange ones are the least inclusive. This means that there is a lot of difference between the states. This is very much related to the fact that of how immigrants are receiving or not receiving, or having an environment in which they can have a better lifestyle in regards to health. That's why we are finding that in these times of financial crisis, that is unprecedented due to COVID-19, the punitive policies and how public burden that contributes to a dangerous reduction in medical care. Also, these results during a national healthcare emergency and a financial crisis, a threat in extending the current crisis to the future. The policies need to be developed while we promote comprehensive efforts to be able to support our communities, including migrants, and defending the use of medical attention and the promotion of equity in health for everyone, especially the recognition of our heritage as migrant nation as a benefit for the country. It's important to support inclusive policies and for people in general. Thank you very much. Thank you, Dr. Rodriguez. We would also like to ask you if you have any successful experience in health that you could share with us in regards to inclusive policies that maybe you know that have happened in the field of healthcare. Yes, in California, what we did, well, unfortunately, we have seen here the health determinants that when we don't have access to the capacity of being able to handle, to drive, you're limited in your capacity to work and to have income, to be able to have food, lodging, etc. for your family. This was because the law would not let undocumented people be able to drive. So we did very hard work with the politicians and with the networks, community networks. We were able to pass a bill that would let anyone, not depending on the fact that they had documents or not, but they would let anyone drive, would allow anyone to have a driver's license, and this has increased the quality of life and improved access to education and better abilities to have vaccines and other examples in health. Thank you very much. Thank you very much, Dr. Rodriguez, for sharing with us all your points of view about all these issues and the success cases. It's very important what you're saying and about highlighting how the policies can determine these experiences that migrants have in the different countries. How from the policy we start looking at the inclusion and exclusion phenomena, and these policies linked to social determinants, and how within the within healthcare these social determinants both affect, but there are policies in the different fields that are determining the experiences in health of migrants. Thank you very much for your contribution, and now we continue with our next panelist, Dr. Engelby, who we want to ask, greet first and ask what it is, if he can explain in a more specific way, what is MIPEX about? What is its methodology, so we can get to know it in greater detail?
Thank you. Well, greetings from Holland, and it's a great privilege to be invited to participate in this very important webinar. I'll be happy to answer your question. It fits into the general topic, how can health systems be made more inclusive for migrants? I'm going to talk about the importance of good data and research. And I'm going to describe an instrument that's been specially designed for assessing migrant inclusion called the MIPEX Health Strand. It's been recommended for this purpose by the UN's Global Migration Group in 2018. Now, I'm going to tell you also about some of the findings from Latin America. So this is my first slide. Why are good data so important? Well, you know the slogan, no data, no progress. Well, the current slide shows why you don't get any progress if you don't have good data. Well, first of all, you need to identify the important targets for reform. What are the weakest areas of your health system? Then you need to monitor the progress of reform to see if there's improvement. And finally, you need to evaluate the success. So, next slide, please. I'd like to remove one misunderstanding, possible misunderstanding straight away. Using standardized measuring instruments doesn't mean you believe in standard solutions. There are no cookie-cutter solutions. The context in each country is different, so the priorities and the constraints will be different. And the most important thing about the context is of course, the number and type of migrants a country has. But the second most important thing is economics. What can the country afford to do? But whatever the policy, we must have a common language in which all the words mean the same thing, all the terms mean the same thing. Otherwise, we can't discuss these issues. Now, the MIPEX Health Strand is part of a larger instrument called the Migrant Integration Policy Index. And this was set up in 2003 to measure how successful countries are at helping migrants to integrate. It was originally a European project, but it was planned to be used in any country that migrants go to. And at present it covers 52 countries, and the number is always increasing. Now, before 2015, MIPEX looked at 7 areas of integration, or strands. That's what you see at the moment. And in 2015, we added the health strand. That's the next slide. Yeah, that's right. And it took a long time. It took 3 years to develop and pilot the strand. And the work was spearheaded by IOM in Brussels. Dr. Adnikov mentioned the project EquiHealth. It was a very, very big project. It was about 160 researchers in more than 40 countries. And my task was to coordinate the project. You can read about this first phase in the following report on the next slide. Yeah, the summary report. Now, you can easily find a copy of that just by Googling MIPEX Health Strand. And there's also another publication on the next slide in the European Journal of Public Health. There's a link to it, but you can also Google it. Now, the big question is, how do we decide on which questions to ask? Unfortunately, an incredible amount of work has been done in this century to answer this question. When I started doing this kind of work in the 1990s, it was quite possible for one person to keep up with most of the literature. But the next slide shows you how fast peer-reviewed articles on migrant health have increased. Next slide, please. Yeah, since 2000. You see this steep rise. And that doesn't include the enormous number of books and reports that are classified as grey literature. At first, most of this was about high-income countries, which most migrants went to at the time, but more and more research is being done in the global south. And at the same time, international organizations have produced a series of high-level declarations and resolutions to try to persuade governments to give more priority to migrant health. Now, I call this the roadmap. That's the next slide. You don't have to read all the tiny details, but you see the agencies involved and the date of the declarations. There's 11 important steps on the roadmap, and there are many, many more. There's also at regional level, very important. Now, none of these organizations can compel national governments. They can't force national governments to improve their policies. So we call these documents soft policy instruments. And they may be soft, but they're still quite effective in providing arguments and data to motivate governments to act. Now, I highlighted one of these steps on the roadmap. That's the Council of Europe recommendations, because those were the ones which we took as a starting point for MIPEX, for the health strand. And they were based on 2 years of research and consultations. And as you know, the Council of Europe is not the European Commission. It's not the European Union. It's a much larger area. It's the United Nations European region, and that's much more than the EU. It has Russia and many other low or middle-income countries or member states. So these recommendations are really applicable to all countries, not just high-income ones. Now, my next topic, next slide, please. Yeah, I'm going to run through these the indicators that we used very, very quickly, give you an idea of what the questions are. And the first thing we look at is access. And we define that as the process of getting into the health system. What happens when you're inside is another question, but access is how to get there. And the most important part is legal entitlement. And as you know, it doesn't necessarily mean free care. It means protection against the risk of medical expenses that you can't pay for. Just as national citizens have or should have. And we study entitlements separately for legal migrants, asylum seekers, and irregular migrants, because they nearly always have different entitlements. Then the next dimension is, we call it the accessibility of services. These are less rigid barriers. First of all, migrants must have information about their entitlements and how to use them. They also need to be given health education and health promotion activities. And this has been an extremely important activity in the COVID-19 pandemic, because a lot of migrant communities have simply not been receiving information, the information they need to stay healthy. Then you can use cultural mediators who show migrants how to navigate the system. And finally, if their papers are not in order, they need to be sure that their details will not be given to the police. So next slide, please. Thank you. Once you're inside the system, the main issue is the responsiveness. of services to the needs of migrants. And perhaps the biggest one is for many migrants, the language barrier. And it's important there should be interpreters available. And staff also need training in dealing with people from different cultures and backgrounds. The workforce, ideally the workforce should itself be diverse. And sometimes you need special methods of diagnosis or treatment to look after migrants optimally. And finally, there are very big important requirements for achieving change. As I've said, you must have good data and research, not just health data, but also, if you like, historical and sociological and demographic information about the people you're trying to look after, about the different groups. Then you need governance. Governments must give leadership, and the efforts of different stakeholders, especially migrant organizations, should be coordinated. And then last but not least, the government should get all sectors to cooperate in providing healthy living and working conditions for migrants. And for countries in the early stages of mainstreaming migrants into the health system, this last section, how to achieve change, is perhaps the most important. And I think it might be a good idea to make it, first of all, more detailed, expand it, add more questions, and put it at the beginning. It's the first step. It shouldn't be considered the last thing you do. So that's what was in the MIPEX health strand.
Thank you very much. Your presentation has been very detailed and very clear. I think you have let us see the methodology, the dimension of the methodology with the most relevant aspects to be able to really do a diagnosis of how inclusion is evolving within the country. So we'd like to ask you what kind of experience and results you have achieved with the application of this methodology, specifically in Latin America.
Start with Europe. The first round of MIPEX was in 2015, using data from 38 countries. This map, this colored map, hang on. This shows you the things that we found. Are you hearing me okay? Yeah? Good.
Yes.
This map, I don't want you to take this map too seriously because it's only considering the total scores. And a lot of the important information is in the details, the different dimensions in which countries are strong or weak. But it's very interesting because, you see, red is the best score and blue is the worst score, and yellow is the average score. You can see that Eastern Europe, for example, have very few migrants, and they mostly have few migrants and small budgets. And in the other countries, there are interesting differences. For example, in France, you have extremely good entitlements, but very little responsiveness to diversity. And in the UK and the USA, which is in this block on the side, in the USA, the opposite is true. Very poor entitlements, but a lot of attention to what they call cultural competence. Now, what are the characteristics of high-scoring countries? Well, you know what the answer is: money. GDP per capita, the gross domestic product, predicts more than half of the variance in the total scores. But part of this is probably connected with the number of migrants in a country, because rich countries usually attract many migrants. And in Eastern Europe, you have, like I said, few migrants and little money. So there's not much effort made to make the system inclusive to migrants. We also find that the political ideology of a country also plays a role. More egalitarian countries tend to give more rights to migrants, not just in health, but also in other areas of integration. So this was in 2015. Next month, in December, we will publish new findings from data collected in 2019, 5 years later. And this was a rather special round. We ran into a small problem. The next slide is a picture of how researchers in Europe imagine the European Commission. Next slide, please. Unfortunately, the goose this year, or last year, the goose only laid a very small egg for us. So we only had enough money to investigate the most important issues. But we call these the core indicators. But the result turned out very well. We were very pleasantly surprised with the result, because even with 12 indicators instead of 40, which we used to have, it was still possible to see whether there had been a change from 2019, from 2015. And overall, we saw there's been a very small but significant improvement in policies on migrant health. Some of it could be related very directly to political changes, for example, in Spain and Portugal. And another factor was we had a big influx of asylum seekers in 2015, and that led to some improvements in healthcare for asylum seekers. Now, in the latest round, MIPEX added 30 new countries, so mostly from the global south. And in Latin America, we studied Argentina, Brazil, Chile, and Mexico. And we're still making reports on these countries, but if we just look at the total scores, we get a picture like this. You see Chile is getting the highest score, Argentina is an average score, and Mexico and Brazil are below average scores. And it's very interesting when you relate this to GDP per capita. It was a real surprise when I did this. It's a very close relationship. Have a look at the next slide. The next slide, please. Yeah. Now, that is amazing, don't you think? Because the R squared, the amount of variance explained, is 0.958. And of course, I was just lucky. When I add more countries, I'm sure it won't be so clear. But you can see a very clear relationship with GDP to the health scores. So just to finish, what have we learned? What are the main things? Let's have the next slide, please. If you've got one. Yeah, you have. First of all, the data needs to be reliable and standardized so that everybody knows what you're talking about. You can't just say, we have good entitlements or we have good access. You have to be very specific. That doesn't mean that policy reforms all have to be the same, because the context and the needs are different. As we've seen tonight, I mean, in Colombia, the big preoccupation is the refugees from Venezuela. In Mexico, many migrants are in transit to the USA. Every country has its own preoccupations. So we might find if we use MIPEX in more countries, we may need to expand some issues, but we hope to keep to the basic framework. And I hope I've convinced you that the framework we have is a good starting point. So, thank you very much for your attention. Amen.
Thank you very much, Doctor. It's very important that you have shown us this methodology, and through the analysis of the information that you, as you're saying, to be able to have follow-up and look at the evolution of the policies and what is the success of the policies in the topics of migration. We now continue with our last panelist, Dr. Miria Orcot, and from the experience that she has had with her work with the Lancet, we want her to explain how this work has been focused on this generation of policies, and if you can present a specific case.
Muchas gracias, viceministra, y muchas gracias a los organizadores y los otros panelistas. Mil disculpas de tener mi presentación en inglés. It's a real pleasure to be here representing Lancet Migration. We're a global collaboration between the Lancet and researchers, implementers, and others in the field of migration health that aims to address evidence gaps and drive policy change. Today, I will highlight some of our main findings and recommendations which relate to inclusion of migrants in health systems and access to healthcare globally, and provide a few examples from our work on integration of migrant populations in health systems and policies, particularly relating to our analysis during COVID-19. So the UCL Lancet Commission on Migration and Health, which you see on the slide, was published in December 2018 and was the result of 2 years of work of 46 authors over 20 global institutes. The main messages from the Commission on how to include migrants in universal health coverage still are just as essential to public health today. In fact, creating such systems that integrate migrant populations will benefit entire communities with better health access for all and positive gains for local populations. Therefore, this coverage should be championed by politicians and healthcare leaders alike. The next slide, please. There have been a substantial number of policy advances, as mentioned by the previous panelist, in the field of migration and health in the last decades, including international instruments, declarations, and resolutions developed relating to migration health. Most recently, the Global Compacts on Refugees and Global Compacts on Migration, the Global Action Plan on the Health of Refugees and Migrants, and the High-Level Declaration on Universal Health Coverage last year at the UN General Assembly. However, in reality, much still remains to be done to realise health for all and to ensure inclusion of migrants in health systems. Our Commission found that there is a growing trend globally of states limiting access to healthcare for migrants, with migrants often being met with punitive border policies, arbitrary detention, abuse and extortion. And also that migrants often face health restrictions on entry. For example, according to UNAID, 35 countries impose travel restriction on people with HIV. Linking health data to migration enforcement reinforces distrust of the health system and limits migrants' access to healthcare, as well as the overall public health response. There have been examples of leadership in the provision of open health systems for all migrants. For example, in Switzerland, the Migrant-Friendly Hospitals Project, where entitlements and access to coverage within the insurance-based healthcare system during this project were nearly identical for migrants as nationals. However, in many countries, national regulations and legal status interact to create barriers to health services. Even in countries such as Italy, which have national constitutions that assert the right to healthcare for every person, the reality is that migrants often continue to encounter obstacles, including discrimination, cost differentials, and administrative issues. Next slide, please. So what did the Commission recommend in terms of a health systems framework for migrant access to health and social protection? Our framework is underpinned by concepts of equity to emphasize human rights and equal access to healthcare regardless of status. The framework explicitly defines health and social protection by highlighting both the supply side, or accessibility of services and determinants of health, and the demand side, or the ability to access services. Both are influenced by geographical, economic, and institutional factors, including law, but then again, they all exist within the broader context of how governance institutions define and protect the rights of people to access and use health services. In order to effectively address health inequities, access to healthcare through universal health coverage should ensure the health needs of individuals, migrants and refugees are fully integrated into existing national health structures with sustainable systems in place to ensure support to refugees and migrants in navigating the system and responding to the needs of all persons without discrimination. Next slide. In order to address barriers to include migrants in healthcare, the Commission recommended that health systems should ensure diversity in service delivery, cross-jurisdictional networking and interoperability, and protection of the rights of individuals and communities to access health services. At policy level, the Commission recommended governments can commit to appointing a government migration and health focal point that can engage across multiple sectors, providing inclusive health and social care that appropriately meets migrants' needs, and ensuring multilateral and national health insurance funding mechanisms incorporate migrants. Next slide, please. So how does Lancet Migration engage with generating inclusive migration health policy? We work to bridge the divide between research, policy and practice to improve migration health by transforming evidence into action. One of our main areas of policy work over the last 2 years has been on inclusion of migrants in universal health coverage. Next slide. We have worked at both global policy level through organisation of official side events on the topic at the Global Compact for Migration, the World Health Assembly and the UN General Assembly, bringing diverse stakeholders together and producing policy briefs and recommendations. Next slide, please. Additionally, through parliamentary and research policy roundtables over the last 2 years in countries across all regions, we have also organised events with UN entities and national governments and have entered into research policy dialogue at national and regional level. This has resulted in more sustained engagement at the regional level with the formation of regional hubs, such as the Lancet Migration Latin American Regional Hub. Next slide, please. And one of our board members is here today with us. In terms of our engagement, we're also engaging across other regions as well at present. So in terms of a specific example examples or case studies, if we go to the next slide, you can see that we've taken part in a number of evidence-based advocacy and policy engagement activities, particularly over the last 8 months. So I'm going to focus mainly on during COVID-19, which has been focusing on inclusion of migrants in the health system response to COVID-19. This has ranged from a global call to action in April 2020, signed by over 700 academics and public health professionals worldwide, where we called for urgent, universal and equitable access to health systems, preparedness and response. Next slide, please. We also called for inclusion of migrant and refugee populations in the health protection responses, and particularly for migrant-inclusive public information strategies, which were urgently needed. Next slide, please. We have also produced national policy briefs on COVID-19 response and migration, and following on from this, for example, in the UK context, organised a joint advocacy and policy engagement campaign over the last month in the UK in collaboration with an NGO and professional medical organisation to ensure access to healthcare for all during COVID-19 and also beyond. Next slide, please. Our series of 20 country and thematic situational briefs hosted on the Lancet Migration website and covering countries across Europe, Asia, the Middle East, North America and Latin America have demonstrated some trends of further marginalisation and exclusion of migrants from the health system response during COVID-19. The three main factors we have identified as impacting on the health access for migrants across contexts during COVID-19 during initial analysis are firstly health system factors, such as lack of capacity and inclusion in existing health systems and health services. Secondly, multiple barriers in accessing healthcare, such as immigration status and language barriers, and these are often barriers that have been exacerbated during COVID-19. Secondly, broader socioeconomic factors, for example, deterioration of living conditions, particularly notable in conditions in detention, pre-existing poor health and comorbidities, increased economic precarity, for example, with COVID-19 increasing unemployment and loss of livelihood for many migrants and reducing remittances also globally. And finally, political factors, which the other panelists have also mentioned. And we have actually seen an extension of many times often already disadvantageous immigration policies during COVID-19. Unfortunately, this has resulted in a protection crisis for many asylum seekers and refugees during COVID-19 due to the suspension of resettlement schemes since March this year, reduced access to asylum processes, increased deportation and detention, and border closures, which have resulted in many struggling to return home. These factors have primarily been driven by a biosecurity-driven response, rather than a response rooted in the public health principles of inclusion and right to health, but also by restrictive measures of lockdowns, such as physical distancing and movement restrictions, which in migration contexts have often been applied not in a way that's proportionate to public health need. And finally, because of insufficient resource allocation to actually ensure inclusion of migrant refugees during the COVID-19 response. Many migrants, asylum seekers and refugees therefore experience a combination of the impacts of a health crisis plus socioeconomic impact and failure of protection mechanisms, all compounded by COVID-19. Next slide, please. We can see clearly the public health impacts of exclusion of migrant populations from the health system by looking at Greece, one of the receiving countries for migrants crossing the Mediterranean. Pre-COVID-19, we wrote in The Lancet about the EU migration policies already driving a health crisis for asylum seekers on the Greek islands, where in January 2020 there were more than 42,000 asylum seekers residing, even though facilities had a maximum capacity of 6,000, just over 6,000. Additionally, there was exclusion already of asylum seekers from the health system with the removal of access to the social security number of asylum seekers and undocumented migrants from July 2019. Next slide, please. During COVID-19, for asylum seekers and refugees in Greece, there have been stricter and earlier restriction of movement than the general population, with continuous lockdown for the last 9 months for those in the mainland refugee camps, as well as the reception camps on the islands, even though no cases of COVID-19 were reported in the island camps until August. The lockdown conditions resulted in increased risk of infection from COVID-19 due to overcrowding and poor sanitation. And by September 2020, unfortunately, there were much higher numbers of COVID-19 confirmed cases per 100,000 population in refugees residing in the reception and identification centres and in open refugee facilities on the mainland than that found in the general population in Greece. The severe restriction on movement since March 2020 for asylum seekers and refugees has therefore had a negative public health impact, as well as significant negative effects in terms of living conditions, food provision, and health access. Next slide, please. This data reinforces the ECDC recommendation that there is no evidence that quarantining people in reception detention settings effectively limits transmission of COVID-19 or has any additional benefit for the general population. It also emphasizes the importance of equal and urgent inclusion of all migrant populations within the COVID-19 response in order to ensure that both prevention and treatment of COVID-19 is readily accessible. A couple of months ago, The Lancet wrote that COVID-19 has shown our health is only as good as the health of the most vulnerable among us. Never before has the Leave No One Behind pledge felt more urgent. And surely the response to COVID-19 brings into focus the continued need to prioritise the inclusion of migrants in health systems and health policies to ensure the public health of all. Without making it a priority to include the populations who are furthest left behind, not only will we not be able to overcome COVID-19, but also the Sustainable Development Goals and commitments to universal health coverage will not be met. Last slide, please. Thank you.
Thank you very much to you, Dr. Miriam. We thank you, and we close this panel by thanking all of our panelists for having shared in such a generous and clear way all your points of views and experiences that you have had in regards to the migration phenomena to be able to achieve inclusive policies in all the sectors, specifically related to healthcare for the countries who are living this situation and this migration phenomena recently. In a way, it's really useful to see how all the works and publications, methodologies, and experiences allow us to take advantage of these experiences that other countries have had and the way that you have faced them successfully, regardless of the common area, which is the scarcity of resources to be able to do inclusive policies. But that obviously allows us in countries such as Colombia to have and expand our vision on the possible solutions that we can adopt to be able to understand the problems of the migration phenomena, evolve, and seeing it more than as a problem, seeing it as an opportunity. Thank you very much to all of you. Thank you very much to all of our panelists and our moderator of the second block. We would like to finish with few closing remarks for the director of the Healthy Communities Program of USAID, Dr. Miguel Pulido. Thank you very much. And on behalf of the Comunidad Saludable program of USAID, I wish to thank our panelists and to all of you, the over 300 attendees. This was undoubtedly a very valuable space to share experiences that will surely contribute to Colombia for the creation of an integration policy of migrant population. Thank you very much and have a good evening. Thank you very much to all of our participants. Thank you to all of our panelists. We will be sharing the minutes of this space very soon, and we invite you to respond to the survey that you will be getting in your emails shortly. Thank you very much.